Welcome to Senadhipan Education Foundation. Unless you try to do something beyond what you have already mastered, you will never grow. Actually, we started this knowledge sharing platform way back in 2007. This is Antonio Longo from Italy releasing my teaching brochure. Then we launched the Senadhipan Education Foundation 2012. It was launched by Professor Sion Han Kim. And then we started the free fellowship program, 6 months and 1 year fellowship program, basic and advanced laparoscopy surgery with contact classes and hands-on training. Last year, 2020, July, we started online programs, and the logo was released by Professor Parenchyma. Then we started live surgeries in online platform, first in Facebook Live, then in YouTube Live. The link was shared to the members of Senadhipan Education Foundation. Recently, we started international fellowship program in SPB surgery, colorectal surgery, and upper GI surgery, minimally invasive. We have appearance in social media. We have almost 20 WhatsApp groups. And in the season 1, we had 28 talks with international speakers. And we have got a very good global acceptance, more than 60 countries. You can see the participation. Last webinar was by the ERA's president, and ERA Society tweeted in the their wall that one of the largest online meetings with over 1,400 delegates from 72 different countries. All the webinar videos are available in the YouTube channel of Senadhipan Education Foundation. Last week it was thoracoscopy. Now we are honored to have a international surgeon who has pioneered parenchymal sparing liver surgery, who has popularized parenchyma sparing liver surgery worldwide. He is author of ultrasound guided liver surgery, and he will be formally introduced by my colleague Dr. Monish Karnagaran, and it will be moderated by Dr. Shiven Singh. And Dr. Monish is consultant in GI surgery in SK Hospital, Trivandrum. Before that, I request all the participants to mute their mic. If possible, kindly acknowledge by renaming your device. Participants logging from outside and they are requested to reveal their identity in the chat box. Raise your hand. Be entertained one-to-one interaction. Raise your hand if you want to talk. Everybody will be given permission to unmute their mic. If you are on a portable device, please unmute your audio and hide your video. And if you want to contact us, please contact in email senadhipan@gmail.com. I am handing over my mic to Dr. Monish Karnagaran to introduce the speaker and the moderator. Dr. Monish.
Thank you, Baiju sir, for the opportunity. Good afternoon, Professor Guido Torzilli. Good evening, Professor Shiven Singh, all the delegates who have joined us here today. It's a matter of great honor for me to introduce Professor Guido Torzilli. Professor Guido is a director, Division of Hepatobiliary and General Surgery, Humanitas University, Humanitas Research Hospital, Rossano, Milan, Italy. He's also the director of Postgraduate School of Surgery, Humanitas University. Professor Torzilli pioneered newer methods of intraoperative staging with ultrasound, especially contrast-enhanced intraoperative ultrasound. He has himself devised a new intraoperative ultrasound probe.
Monish, can you change your slide to full screen?
So I have, it's full screen.
We are seeing the slideshow.
Okay. In ultrasound-guided liver resection, he conceptualized radical but conservative resection, the concept of R1 vascular resection, and he made us appreciate the role of communicating veins in parenchyma sparing procedures in case of hepatic outflow tumor infiltration. He has popularized many new surgical techniques, including hooking technique, compression segmentectomy, mini mesohepatectomy, SERBs, and upper transversal hepatectomy. Professor Torzilli obtained his MD from University of Milan in 1988, his postgraduate degree in general surgery from University of Milan in 1993. Thereafter, he went on to do his PhD at University of Tokyo, Faculty of Medicine in 1999. From 1998 to 99, he was an assistant professor of surgery at University of Tokyo. 2002 to 2006, he was assistant professor of surgery at University of Milan, and from 2006 to 2015, he was an associate professor at Milan University. From 2015 onwards, he has been a full professor of surgery at Humanitas University. Apart from these, he has been a visiting professor at many renowned centers, including University of Tokyo, Catholic University, Faculty of Medicine, Rome, King's College, London, the Chinese University of Hong Kong, MD Anderson Cancer Center, Houston, Harvard Medical School, University of Oslo, and National Cancer Center, University of Marseille, to name a few. He has published over 480 publications in index journals, which has garnered over 12,440 citations. Apart from this, he has authored more than 50 book chapters. His H-index is as high as 52. He's the editor-in-chief of the famous ultrasound-guided liver surgery and atlas, which was published in 2014. He holds editorial board position at many renowned journals, including Digestive Surgery, Surgery, Gastroenterology, and Oncology, the Journal of Hepatocellular Carcinoma. He is a member of editorial board in many journals, including Liver Cancer, Cancers, Updates in Surgery, World Journal of Gastroenterology, World Journal of Gastrointestinal Surgery, World Journal of Hepatology, Global Health and Medicine, Journal of Ultrasound, to name a few. He has been an invited speaker and chairperson at more than 900 national and international meetings. Welcome, Professor. We're all looking forward to hear from you on parenchyma preserving liver resection. To moderate this session, we have another stalwart, Dr. Shiven Singh, who is the Chief of GI Oncosurgery and Liver Transplantation at Rajiv Gandhi Cancer Institute, New Delhi, India. Dr. Singh did his MBBS and MS from the famous King George Medical College, Lucknow. Thereafter, he did his MCH in gastrointestinal surgery at the prestigious GB Pant Hospital and Maulana Azad Medical College, Delhi. Thereafter, he did clinical fellowships in HPV surgery and liver transplantation from renowned centers like King's College, London, Montsouris Institute, Paris, and Queen's Hospital, Hong Kong. He served as a senior resident from 2001 to 2004 at GB Pant Hospital, Delhi. Between 2005 to 2010, he was an assistant professor in HPV surgery and liver transplantation, ILBS, and he was an associate professor at the same place from 2010 to 2011. Since September 2011, he has been serving at Rajiv Gandhi Cancer Center, but currently he is a senior consultant and chief GI Oncosurgery and liver transplantation. He has published more than 100 publications in index journals. He has been awarded many awards, including French Government Scholarship Award to University of Paris, Saudover Memorial Fellowship Award to Memorial Sloan Kettering Center, Cancer Center, New York, and Traveling Fellowship Award to Second International Society for Gastrointestinal Oncology Conference in Washington. He has been an invited speaker and chairperson at more than 150 national and international conferences. Thank you, Shiven, sir, for accepting our invitation. Over to you, sir, to start the session.
Thank you, Monish. Welcome, Dr. Shivendra and Professor Guido Torzilli to Senadhipan Education Foundation. I hand over the mic to Dr. Shivendra for the first proceedings.
So I'm not sharing the screen.
Dr. Shivendra.
Welcome, Professor Torzilli. It is good to hear you again and hear your good, excellent talk. I think it is a parenchyma sparing surgery that you have propagated has given a good option to a tedious problem, especially for colorectal liver mets, once they are bilobal liver mets. So parenchyma liver resection, sparing liver resection give a good option in this condition. So welcome, Professor Torzilli. You can, everyone is waiting for your talk. Welcome.
Thank you very much. Thank you very much, Professor Shivendra. And it's my real pleasure to join and to meet friends. I was hosted by Professor Shivendra Singh in a meeting. It was really a pleasant stay in your country, and I enjoyed the discussion that we have and also an operation. So thank you very much for the involvement in this prestigious event, part of a number of events that were attended by stars from all over the world. I saw the program that you had, and now I will share my screen, and hopefully we will start the presentation. So I will try to address the argument that has been asked to me to deal with, which is an argument which I am passionate, as it was pointed out by my CV, is parenchyma sparing liver surgery. I will try to point out this aspect, focusing on the colorectal liver mets, because otherwise it's too big the argument, and moreover to the colorectal liver mets condition has been more expanded because we have more freedom degree to face with more complex condition other than for the ACC and the cholangiocarcinoma, to which anyhow we applied all the procedure that we have released. First of all, I would like to point out that I am a bit older than in the picture that was shown. So this is my real face and the face that you see in the camera. I have no disclosure. I start my talk with a provocative image, which is a case with multiple bilobar colorectal liver mets scattered everywhere in the organ. And I ask, of course, to the audience, if could you imagine surgery in this patient? And if you could imagine surgery, even though after chemo, because of course, chemo provide advance, some control of the disease, is considered very useful also for facilitating surgery. Anyhow, in this case, possibly has not really changed the concern about the resectability or not of this patient, or of this patient. This is the cast of the same patient. The cast of the various tumors, in pink, those who disappeared after chemo. And this may facilitate the decision if to operate or not. What the conventional surgery provide is, as options, are most of the time major hepatectomy, and possibly these are not meeting the requirement to offer surgery to this patient. Even though we split the operation in two phases as a two-stage hepatectomy, there would be not enough remnant liver to offer enough hypertrophy. The other solution is the ALPS, and the ALPS is a short course hepatic stage hepatectomy. Possibly also the ALPS would have not been a possible solution in a patient in whom almost all the segments were involved by the tumors. In the years, as it was mentioned, we with our approach, we open scenarios to various solutions in the liver, and possibly there are infinite more solutions in a complex organ like the liver, which offer per se the solution that we have disclosed, and many others are expected in this sense. Then let's see if this kind of different modality of looking at the organ may open a solution for a patient like this one, and analyzing the steps that we have to follow to understand which is the strategy and the policy in front of this kind of presentation, to try to offer surgery having a different background in terms of approach to the organ. The strategy. Nowadays, the strategy is facilitated objectively by the 3D cast modality. The 3D cast modality offers the estimation of the volume, which is well known, especially for the major hepatectomy. But nowadays, we have investigated this modality to foresee the remnant volume in case of complex dissection. So volume of liver with the morphology, which is quite different than the one expected after a major organ amputation. Well, despite that, we have the ability to foresee the future liver remnant quite in line with the final results, without then any discrepancy about what we were foreseeing before surgery and what we have seen after the removal of the disease. These are two cases that are shown and published on this article. The 3D cast offers us to look at the liver in the 3D real condition, and then to disclose two aspects which are fundamental to offer surgery in a parenchyma sparing fashion for this kind of presentation. The cluster, the first one. What does it mean, the cluster? We have to find out, to offer surgery in this patient, we have to be able to identify cluster of lesion, which can be grouped in resection area. If this is possible and the future liver remnant is enough, the operation can be done. And in this case, we can find 4 clusters and 3 isolated lesions. The other aspect are the compass points. The compass points are the flags that delineate the border of the cluster, and which are very important because intraoperatively we have to search for the compass points, because identifying the compass point, it makes feasible delineating the resection area precisely and being sure that you are including all the lesions that you were planning to remove with that resection area. Then you have the red circled lesion are the compass point in this situation. The yellow flag are showing those deeper in the liver in contact with major vascular structures, while the blue one are those that are at the perimeter of the resection area. Second aspect, which has really changed this kind of approach, is inherent with the surgical oncology. The R1 vascular, as it was mentioned. My thought was R0 is okay everywhere. R1 parenchymal is suboptimal oncologically, but what's about the detachment from the vessel of the tumor, the so-called what we named R1 vascular? We know from the anatomy that every major vessel into the liver is not separated only by the Glisson capsule for the portal pedicle and the vessel wall, or the vessel wall for the hepatic vein, but also by the Lennec capsule, so which envelop the entire organ and separate the organ from the inferior vena cava. So the Lennec capsule is something that envelop the organ, and everything which is outside is separated from the parenchyma from the Lennec capsule. So we could assume that even the major intrahepatic vessels are something outside, some external aspect. Then why not the touching? And well, we explored this fact since 2006, initially for the ACC in reality, secondary for the Mets, because it was a dogma to leave some liver in between the hedge and the colorectal liver mets, so that I was very young and I challenged this dogma step by step. Well, in the years we have grow up a series with the consistent data. This was published 10 years after we started, and we saw the R1 vascular at the local recurrence for the colorectal liver mets, which is similar to the R0. And this is possible not only for the Gleasonian pedicle, but moreover for the hepatic vein at the caval confluence. Why? Because you can also, you have the second solution rather than the amputation. You have three solutions: amputation, but also another solution is, of course, the detachment, and the hybrid solution is detachment with partial resection of the vessel wall. And we saw that this is possible with this offer solution of sparing the veins and then exposed to a local recurrence, which is in line with the R1 vascular R0, which was mentioned. In case we could not avoid the amputation, there are possible adjustments. And these adjustments comes from the anatomy, from the liver. We do not have to do anything then recognizing these adjustments. This is a tumor at the caval confluence invading the middle hepatic vein. It is involving the segment A, segment 4 superior, and the segment 1 paracaval, and also the caudate lobe. For this patient, we found, as it happens almost constantly in this condition, collateral circulation between the interrupted hepatic vein and the right hepatic vein, as shown in this picture. There were two collateral circulation. And then we planned the liver tunnel, and this was the operation with amputation of one vessel, but sparing of the entire organ except the tumor and some parenchyma surrounding to the tumor itself, and detaching, of course, the tumor from the right hepatic vein and the left hepatic vein. The fourth aspect, which is probably the most fancy one, well disclosed everywhere, is the guidance. The guidance, of course, implies the use of the ultrasound. Not only the ultrasound, but of course, the first step is the ultrasound. Ultrasound makes transfer in the liver. You see the landmark. You know, are taking profit of the complexity. You are not fearing the complexity anymore. The fingers, of course, in the open setting, in such a complexity, up to now is compulsorily, the finger are helping a lot because are the landmarks to drive the dissection and to follow the dissection properly. This is the preparation for a liver tunnel. You see the end is after entire mobilization of the liver is just between the inferior vena cava and the organ, and is gripping the Arancius ligament. And then the fingers can be visualized. The electrocautery indicate where you are starting the dissection. You are planning to start dissection. Then the finger here. Then the dissection that you are figuring once you are planning to resect the middle hepatic vein invaded by the tumor. And then this is the relationship passing through the tumor and the Gleasonian, the dorsal aspect of the P5A, the Gleasonian pedicle to segment 8, 1 paracaval, and 5. And this is the area that has been drawn accordingly. And at the end, you will see we have another element which is important at the vessel. And the vessel can be followed since just below the surface of the cuts of the liver, because the peripheral branch of the major vessels can be identified there quite easily. And then following them, we can, as in this case, expose the middle hepatic vein. In this case, middle hepatic vein has to be divided, and just below there are we follow the dorsal aspect of the umbilical portion, the left portal vein. And from there, we follow the dorsal aspect of the P5-8, and we are going towards the resection and division of the segment 8 portal branch. These open the angle in between the P5-8 and the right hepatic vein and the P7-6-7 behind. And then at the end, we do this kind of complex dissection following the indication of the ultrasound, the trajectory that we planned initially, and mainly the vessel intrahepatically. At the end, this is another liver tunnel. The last aspect is the disappeared lesion, because once the oncologist possibly considering the major hepatectomy as a rule, believe, to me wrongly, that making disappear the lesion is profitable for the surgeon, which is not the reality. Anyhow, we have the solution. With the pre-chemo imaging, in this case, we can upload the pre-chemo imaging in the ultrasound machine, which can be merged with the intraoperative ultrasound in real time. And according to the relation with the major vessel, we can identify the area in which the lesions were located, although not anymore visible. Then in this patient, in example, pre-chemo cast, several lesions scattered elsewhere. After chemo, MRI show only 5 lesions. Well, with the fusion imaging, we identified the compass point in red and circled, the cluster, yellow, and the dissection, and which can be done also according to the same relationship, but at the ultrasound. And then drawing on the cut surface, resecting all the lesion where the compass point was, and the removal of 37 lesions, only 5 still visible. The results with this modality, collateral vein, communicating vein, and detachment, we have, in most of the cases of complex presentation, parenchyma sparing resection can be offered, like in this series of tumor, at a hepatocaval confluence. The major hepatectomy are really exceptional. This is our series updated on September last year. We have now, 407 enhanced one-stage hepatectomy, not 396, 483 number of lesions removed, 10 lesions in median per patient, only 10% of major hepatectomy, 0.7% was the mortality, and most of the patients were more than 60% of the patient had R1 vascular surgery, and 20%, 1/5 bilateral R1 vascular with major means this contact, not the peripheral one, zone H, zone P, which means formally unresectable. The R1 vascular bilateral has no difference in terms of long-term survival with the other, despite, according to the oncological dogmas, these patients should not be offered surgery. This patient can be reoperated more frequently because you keep the skeleton of the organ. This patient had 36 lesions, diffusely scattered elsewhere. We had to expose the tumor. There was a mini tunnel here between the left hepatic vein, and this is the exposure of the middle hepatic vein, the right hepatic vein. This slice of the organ was fed by these 2 branches of Grisonian pedicle, and the tumor was removed from this. And there was also removal of the left lobe partial resection. And anyhow, this patient can receive this surgery, further surgery, in the event of further lesion. These pink are cyst. And again, with the detachment, and this kind of condition happens in 62% of our series with liver-only liver recurrence. The comparison, then we have challenged, we have challenged the 2-stage hepatectomy, the Paul Bruce. They dictate the inclusion criteria for the case match comparison, and we show that the single operation is better. There are no dropout in terms of intention to treat, and is also safer in terms of outcome. And then saying that the 2 stages selecting the best patient probably is not true, because we should have included that patient, but the recurrence-free survival was exactly the same. And we were challenged by the Alps Italian registry. Like the Alps Italian registry were 12 centers versus 1 center, but they couldn't offer a number of patients with the complexity that we dictated to compare in a 1-to-1 fashion, that we have to accept the 1-to-2 fashion, 1 from the Italian registry, 2 from our center. And at the end, you see mortality and the complication is no discussion in favor of 1 stage. Of course, we had more R1, but because we accept R1 vascular, and we have never had R2. The R2 are the dropout, of course, because you leave the patient that you cannot operate anymore, but with the tumor remaining. And then this patient had is an oncological failure. The survival and disease-free survival were equals, but we were offering surgery to more advanced disease with lower mortality. Reproducibility in the years, my staff do most of the operation by themselves, and I decreased my activity. At a certain point, there was an alarm because I am not so close to the retirement, and I decided to redraw my activity to defend a bit my position. The patient that we mentioned initially, you remember the cluster, the compass point, and the simulation. This is the real patient, the dissection area that we did, and this was the surgery. We have to detach, we had skeletonized completely the mid-hepatic vein, and we detach part of the vein, of the posterior aspect of the vein, and remove selectively this tiny lesion, which was shown at the contrast enhanced intraoperative ultrasound, and still visible also at the intraoperative ultrasound alone. And there was, of course, the detachment from the middle and the left hepatic vein, also for this lesion, the cover conference. At the end, this was the surgery that was done, a so-called roller coaster operation, with the removal of all the foci. The future, and then I move to the conclusion. This is the results of path that we have followed in the years, offering new solution and increasing our expertise also, and the confidence with the procedure. We were able to arrive to the total upper transverse, the liver tunnel, and whatever, and combining this procedure all together. And then from the established, this is a case of upper transversal. This is the huge tumor here. Instead of trisectionectomy or whatever, we do just the removal of the upper part of the organ, taking profit of the existence of the communicating vein. 2 new intrahepatic trails that we use to face according to the presentation. So the solutions are almost infinite. And nowadays with the cast, we have also the possibility to better simulate the resection, like in this case that we have nominated quite recently this operation that also show hepatectomy. At the end, with this modality, you can remove a lot of lesions. There are 2 main clusters, the compass point, the dissection area with the fusion imaging, and then at the end, we remove, in this case, as a peak of our series, 83 operation in a single operation. The challenges, well, we have tried to standardize the procedure to make it more popular, because I understand that most of the colleagues are somehow scared by the difficulty, of the kind of surgery. But if the surgeon understands the geometry of the organ and look at the geometry of the organ as a offer of the organ to be dealt with, this will be considered an opportunity, not something to avoid. And then we need to standardize the procedure. Standardization path through the vessel, the ultrasound, what I have already said, and design a new kind of surgery, parenchyma sparing vessel-guided major hepatectomy, which is not a paradox. And to offer this kind of surgery we need the cast, we can improve the virtual simulation, and with the artificial intelligence, possibly we will have also, with the huge series that we have obtained, the possibility to offer standardized simulation for the different pattern of presentation that can be faced with. Bridging to MALS, to minimal access liver surgery. I used to say this acronym rather than minimal invasive liver surgery, because if you do a 3-sectionectomy with laparoscopy, you are not doing a minimal invasive surgery. You are doing just a minimal access liver surgery, but you are removing 2/3 of the organ. So for the organ, it's not a minimal invasive surgery. And then anyhow, minimal access liver surgery, we have the same situation. We have the preoperative cast, we can simulate, and we are trying to face the complexity. Possibly we cannot arrive to the complexity that is offered now to the patient that I show you, but anyhow, there will be the room for this kind of approach. This is a rare one vascular surgery cover conference. And the other aspect is analyzing the regeneration, because possibly the results of such a result of high safety are probably related to the fact that we do not amputate the organ. And possibly there is a milder, more physiological regeneration, keeping the branching, the main branch of the vascular in and outflow of the liver. And now we are trying to foresee if this is true. And and of course we are dissecting the R1 vascular. And first of all, we have seen that it works for the ACC. We know that it works for the METS. It doesn't work so well for the cholangiocellular carcinoma, for which we consider this option only in case of otherwise unresectability. And the other aspect is, we know that the colorectal liver mets has different kind of growing pattern, desmoplastic, replacement, pushing. Well, for the replacement growth pattern, the R1 vascular is not working well. And paradoxically, we saw that R1 vascular works more in the in mutant KRAS patient, but it does need some further confirmation. The alternatives to this advanced one-stage operation is possibly not the stage procedure, not the ex vivo in situ. What is coming is the liver transplant for the colorectal liver mets. And I think that in the future, this will be the alternative, and possibly sometimes when we could also print the organoid, possibly will be the substitution of all our effort, and we will be looked at like a primitive guy. Thank you very much for your attention.
Thank you, Professor Guido Torzilli, for the wonderful talk. Actually, the slides were mesmerizing. We saw all the pictures very clearly, and the message is very clear. I request Dr. Shivendra to conduct the proceedings with questions from the audience.
Yeah, excellent talk, Professor Torzilli, as usual. Just to start seeing your slides, is there any definition of unresectability in your dictionary? Professor.
If there is someone is considered unresectable, the unresectable patient are those in whom we could not find the cluster.
Okay.
The scattered lesion elsewhere, everywhere, of course, unresectable. I mean, if there is an organ in which we couldn't find any part of the liver.
Dr. Sudhindran has raised his hand. Dr. Sudhindran, can you ask the question directly?
Dr. Sudhindran.
Yeah, sorry, I'm just unmuting. Hi, thank you very much, Professor. That was hypnotizing, as Baiju was saying. My question, two things. One is, what is your technique of Pringles maneuver in this particular thing? I mean, do you do Pringles? If so, how do you do it? How long do you do ischemic preconditioning, etc.? Second is regarding chemotherapy. If you're removing the lesions that have disappeared on chemotherapy, then why give chemotherapy at all? I mean, do you not believe in that at all? So, thank you.
Thank you for the questions. For the clamping, we do routinely the ischemic, the intermittent clamping. We do not do the ischemic preconditioning because it's a sort of intermittent clamping. We just, instead of 10 minutes of preconditioning, we do 15 minutes, then we proceed always. And we have achieved the maximum number. It was published, it was 346 minutes in a patient with 49 lesions several years ago, which who was operated in 2007, 2008. And we have published on Annals of Surgery a paper with a series of more than 2 hours clamping. The outcome was okay. They may say that long clamping, if you take care to sometimes prolong the interval during long dissection, is usually not a problem. And growing the expertise, of course, nowadays, we did not achieve 346 minutes again, but normally more than 2 hours can be achieved almost routinely, and we have no problem. The mortality is very low, and the liver failure, post-operative liver failure also is a safe surgery. And the second question was about the chemo.
Yes.
Well, most of these patients, unfortunately, I don't know, but at least in my count, it comes after long chemo courses managed by oncologists who consider by themselves or by general surgery or general surgeon without enough expertise on the liver, unresectable patient. Then they arrive to us with already chemo already done. Most of the cases, the median number of cycles of our patient are 9 per patient. Generally speaking, I recommend when the patient arrives to me before chemo, still naive, I will suggest just 4 cycles. I just need to show that the chemo is working. I am not against chemo. I think that it is useful. To me, is overestimated unless he will not prove to be able to cure a patient only with chemo. Up to now, this is not feasible. Then surgery is mandatory to be sure not to rule out a patient who is resectable to surgery. And sometimes the oncologists have the presumption to do that, and this is wrong. It's a modality they have culturally. I remember in the ACC, if I have 1 second just to explain this concept, up to 2008, they didn't exist in the history of ACC, the oncologists. There were no drug. At a certain point arrived the sorafenib. It has had a big merit because it has opened the development of other molecules. So I don't want to say that was just useless. It had a big use, but unfortunately entered in the world and established the rule. The oncologist established the rule. And then the patient with the macrovascular invasion that can be operated and cured, 40% of them, were not anymore addressed to surgery, and they were offered a palliation because there was a big business behind, of course. So in this sense, I am sometimes always a little bit in difficulty with that word, but I consider that is useful. And nowadays, the condition, I mean, the environment is so pushed towards chemo that we should find a compromise. I think, and we have some results that are saying that even in the multiple biloba, the help of pre-chemo, or pre-operative chemo in terms of long-term survival is not so sure. But we have to accept. I mean, we have to find a compromise. It's not a scandal. Nowadays, the risk of losing the patient to surgery for progression after chemo is very low. So I think that in a multidisciplinary setting with good relationship among specialists, chemo is an important tool.
Professor Shivendra, may I ask one more question?
Yeah, you can ask. Sorry.
So if in case of when you need vascular resection, for example, hepatic veins, right hepatic vein, middle hepatic vein, etc., what conduit do you use? Do you use Dacron or PTFE, or is it always vein grafts?
No. Most of the time we just do the direct suture. We have done the patching in 2 cases.
Okay. Professor Torzilli, there is one question from the audience. What is the incidence of bile leak in your experience?
8% in our series. 8%, and we measure the bile leak, sampling the bilirubin level from the drains, which are maintained up to 7 days post-operatively.
Okay.
And if it is above 10 milligrams per deciliter, we consider that there is a bile leak. Nowadays, we do the air leak test and it's decreasing.
Okay, Professor Torzilli, there's one question for the audience benefit. What transaction technique you use? Cali Classic, USA, or any other technique? Or what software you use for navigation, for mixing your CT images, fusing with your ultrasound images? What software you use?
Okay, for the crash, the dissection, we use the crash clamping, and nowadays we use an energy device. If you want to know we use the ligature, but I mean.
Ligature and Cali Classic.
Cali Classic and ligature for sealing the vessels, and ligation for the Glisonian pedicle thicker than some millimeters. I mean, and
navigation software.
The
navigation software.
Navigation software is we use the Fuji Synapse.
And it can be fused with any ultrasound machine, or it has to be any specific ultrasound machine to be?
Fuji Synapse is, the Fuji. We have also the Aloca, which is Fuji now, but Fuji is a software that can be uploaded in a computer, and you can do that by yourself. You do not have to send a CT elsewhere. There is a software, and my staff do the simulation, and is independent from the ultrasound machine.
Okay. Any other questions from the audience?
Yeah, there is a question. Dr. Sudhir has asked the experience with the X5O hepatectomy.
No, never done. Never done. I mean, I think my main target was always to, I was educated at Makuchi's department. Makuchi was doing very complex operation in the 90s, very complex operation. I have never seen him doing an ex vivo. And for us, I mean, and I say us as a member of that cultural track, there is no need. The alternative nowadays to the ex vivo is the transplant.
Professor Torzilli, just a question: how you compare your parenchyma sparing surgery if you compare with multiple metastectomy and use of microwave ablation for multiple deeper lesions?
We use the microwave ablation quite rarely. We are not against, I wrote an editorial with Serge Evrard, is a French surgeon that is a main sponsor of this approach. And I agree with him. When you have a very tiny lesion that you discover the lesion intraoperatively in a multiple bilobar setting, and this is occupying just in the central part of the liver that you want to remain, no need to do a major hepatectomy, to do even parenchyma sparing, because in that condition, that parenchyma sparing is a major hepatectomy. You remove too much compared to the remnant liver. And then below the 2 centimeter can be accepted nowadays, even in open surgery, where you can resect easily. Anyhow, if there is this unfavorable ratio between the parenchyma to sacrifice and the size of the tumor, the ablation is okay. I started my experience in the liver with the ablation. The first mentor was Livraghi, the inventor of the ablation technique. And so I am not against dogmatically, but I think that if you can remove, you have to remove. In some conditions, it's useless. Paradoxically, the recent case of liver failure, the major I have had in the last 2 years, is exactly one patient that at the end we discovered a small lesion. Then we did the microwave. For democracy, I always ask to the interventional radiologist to come and do that, because I don't want to do the things that they used to do. Well, the patient has liver failure because of the necrotic area of that. So sometimes the microwave, sometimes you have to take care because the necrotic area can be not so well controllable.
So Torzilli, there are 2 questions from the audience. One is, what is the incidence of post-hepatectomy liver failure in your series? And another question is, any for modified Pringle, if you clamp only the hepatic artery, not the veins?
No, I clamp all the pedicle normally, and except in some circumstances when I mean, you know, there is the left side of the hepatic artery, and the other aspect is the liver failure is 7% of our series.
Okay. And
not severe.
One question or more, what is there any role of adjuvant chemo after your resection? You use in all patients, or?
I don't know how it works in your in India, but in Italy, the oncologists are very strong, and the patient, the chemo is managed by themselves. We just discuss, but they decide. So there is a sandwich approach: before neoadjuvant, and after usually they do the adjuvant.
Okay, oncologists are strong here also in India also.
You know, they have the possibility. There are big problem is they have the if I have a minute, the possibility to with the company organize big study, tons of patient, comparing one pills and the other pills, or infusion and the other infusion. For us, it's more difficult to raise such a huge number of patients in a prospective fashion. So they have the possibility to make a quite elegant publication, as the surgeon normally doesn't. And it's more difficult, but at the end, surgery is still...
Rudra has asked whether you use ICG.
Yeah. The ICG, of course, we use the ICG fluorescence. The ICG in our algorithm is not included, despite I am coming from the Macucci's department. Because when I came back to Italy, the hospital did not buy to me the machine to sample the ICG, so I had to survive, and I devised a modified algorithm without the ICG, and it works because we have a quite really safe surgery based on the bilirubin, cholinesterase, the liver volume, and the stiffness. That's all.
Professor Torzilli, he must be asking for intraoperative ICG fluorescence to locate the lesions.
Yes. The that is, I think, quite essential in the laparoscopic environment, not in the open surgery.
Yeah, Dr. Anil Agarwal is there to ask you about laparoscopic experience. Dr. Anil, can you ask the question directly?
Hi, good evening, Guido.
Hi. Hi,
How are you?
Good to see you. No, to
Yeah,
see
good
me
to
because
see
I
you
just
online.
got the name.
Yeah. So, Guido, as usual, an excellent talk. Really enjoyed, and I think we are missing meeting physical. But anyway, good to see you online, and excellent talk. And I think I just thought maybe you can talk about a little bit about your view about laparoscopic ultrasound-guided minimal access parenchyma preserving resection. I know some of the resection that you showed at the moment looks far-fetched, but you think there could be some headway in this area for minimal access surgeons who are doing laparoscopic liver surgery?
Thank you very much, Anil. It's a pleasure to meet you, although virtually. Everything is virtual now except operation. Of course, nowadays we are trying to. I show some R1 vascular. We are trying to. It is around 15–20% of our activity. The problem is if your image is image towards the other colleagues is the one that operate all the complex, my portfolio of patient is usually of high complexity, and then it is difficult to find the patient fitted for laparoscopy, unless I should shift from major hepatectomy to do a laparoscopic procedure. Because sometimes I understand, I see many colleagues that, we do a right hepatectomy for a tumor in segment 8, 6 centimeters. We will never do a right hepatectomy for such a patient. And then we prefer to do, if the alternative is open parenchyma sparing and major hepatectomy, minimal access, I definitely prefer open parenchyma sparing, because we offer to the patient more possibility of salvageability. Salvageability means cure of the patient for the tumor, because once you offer surgery to the patient, you keep the patient in a curative perspective. If the patient has received a major hepatectomy, although with the small holes in the abdomen, and then after for relapse cannot be reoperated, it's a failure. It's not a good. Of course, I understand this is unpopular. Our challenge is nowadays to standardize and to see, especially in the robotic environment, if the end can be substituted by the virtual reality. Nowadays there are software that read the modification of the organ, read the modification of the anatomy, and this is possibly opening the possibility to dissect the organ in a complex way, even without the help of the hand behind.
Thank you.
Dr. Tony has something to ask about the FLR. Dr. Tony, can you ask the question directly?
Yes, sir. Good evening, sir. So I just wanted to know, what is the minimum FLR that you look for the parenchymal sparing surgeries?
The minimal?
FLR.
Functional liver remnant, sir.
Yes, we keep 40%.
So there is for all type of patients, sir, including cirrhotic patients and cholestatic patients?
For the cirrhotic patient, 50 generally, but we move also to 40. I mean, consider that 40% by most of the surgeon is considered the limit for the cirrhotic patient and 30% for the other. We keep 40% for everyone. In this way, we have no experience with the injured liver after chemo in terms of severe liver failure.
Okay, thank you, sir.
You're welcome.
I think now there are no questions from the audience. Baiju, are there any questions in your? Baiju, you have to unmute. There is one question, Professor Torzilli. What is the management protocol if your histology turns out to be R1 resection?
What is the how to address R1 margin on histopathology? What do you mean?
If on the biopsy it comes out to be R1, whether you think of giving radiation to that area or any adjuvant chemotherapy?
No, if it is R1 vascular, no.
If R1 parenchyma, then?
R1 parenchyma, we do not, no, is accidental because we should avoid it. Although if you look at the expertise in the experience of all the centers all over the world, the number of R1 parenchymal is not so rare, 30% by the North European centers.
Sir, I have a question.
Yeah, Manoj.
Sir, in case of HCC with background cirrhosis, do you recommend parenchyma preserving with R1 resection even to child B patients, or do you just limit to child A or early child B?
No, for the child B patient, I think surgery is not a good option, especially if you mention the R1 compulsorily done resection means the anatomical resection, those resection in which I have to expose the tumor because it is a huge tumor, and which is for us acceptable in case you do an anatomical resection. If you remove the segment in which the tumor is, although you expose the tumor, there is no additional risk of local recurrence with compared to the R0, because you are removing all the part in which the microsatellites could be. The microsatellites, if are there, are in the segment, not in the other segments, because in the other segments would be a distant metastasis, although it is adjacent. Then the microsatellites, if you remove the entire segments, are completely cleared, and then R1 is acceptable. It's a different disease compared to the Mets.
Dr. Jagannath?
Dr. Jagannath, can you please unmute? Dr. Jagannath, please.
Sir, just wanted to know that in an 83-year-old patient, we have got a one liver metastasis of 4 to 6 millimeter following the adjuvant neoadjuvant chemo. In these patients, can we put a hepatic artery port and then give the regional chemotherapy? Any experience on that? Any suggestions, sir? When it is indicated, do you practice that?
Now, we do not practice the intra-arterial chemotherapy, despite the results of the North American, I mean, the memorial essentially have been quite impressive. But no, it's not in our routine. I have no experience in terms of intra-arterial chemotherapy. Especially because we could not use the exact mix of drug that they use in the memorial. Then in reality, with the other drugs, some oncologists proposed me, but I am even reluctant to inject in the artery of the liver, especially if the patient can be surgical.
So one more question,
Please.
So in patients with venous involvement by HCC, do you recommend any bridging procedure before the resection, like tear or something like that?
Yes. If the patient is resectable up front, no. If the patient, I just read a paper yesterday on ALPS for macrovascular invasion of ACC with claiming that it's a good solution with more than 10% of mortality. Well, it's not a good solution. Especially because if you have a tumor thrombus in the right portal vein, you have already done the portal vein embolization. And then if you estimate the future remnant liver, that's all. If it works, the liver, and you have to operate the patient. The nature has offered already the preparation of the organ. There is no need of hearts. It's incredible. But so I think that I use the radioembolization if the tumor is in the main portal trunk, which decrease the possibility of surgery to offer oncologically adequate solution in long term. Then if it's a sort of downstaging for surgery.
Dr. Shivendra, I don't think any more questions are there.
I think, yeah, everything has been covered. So excellent.
Any questions are there? Please raise your hand. You can direct. You can.
There is one question only, that is there any role of portal vein embolization in your algorithm?
We use it in case of Klatskin.
For Klatskin.
For Klatskin, of course, we have the only option to do a major hepatectomy, often left trisectionectomy. So
I think there are no questions. And
thank you, Professor Guido Torzilli, for accepting my invitation, and Dr. Shivendra for introducing Dr. Guido to me. Thank you, Dr. Monish, for introducing the speaker and the moderator. Actually, it is a blessing for us. A figure like Dr. Guido Torzilli is addressing our audience of Senadhipan Education Foundation. We request your presence for our future endeavors also. Thank you, Dr. Monish, Dr. Shivendra, and Dr. Guido. Shivendra, for your final words.
It was an excellent talk. I think Professor Torzilli interacting with the surgeons will give a lot of hope. In enthusiasm of the students increases, and a lot of people have asked for your course, which is very well awaited for your course on intraoperative ultrasound. One question has been asked audience also. They are all waiting for your course to start.
We are. Sorry. We are planning to restart. The problem was the COVID.
Yeah.
The only problem was the COVID. We have done 2 webinars, which is a different things compared to the real procedure. And we hope we could redo the course that we were doing, which was very successful and really enjoyable also by my side.
Thank you, Professor Torzilli, for giving your valuable time for this.
Thank you, Professor. Once again, we will meet physically in one of the conferences. Till then, bye. Dr. Monish, thank you for involving, and Dr. Shivendra for moderating session. Once again, Dr. Guido Torzilli, wish you a good night.
Thank you very much. I have still to have dinner. Anyhow, thank you very much. I enjoyed really very much. I enjoyed.
Thank you so much.
Thank you for the honor. Thank you.